becoming more important in contemporary days because in every emergency department, you should exclude acute coronary syndromes based on presence or absence of positive cardiac biomarkers. And for acute coronary syndromes, we are discussing about troponin, and actually it's about high sensitivity troponin, and also in Romania, most of emergency departments are performing high sensitivity troponin, and CKMB, it's myocardial fraction of CK. So we have 3 levels of assessment. Sorry. Three levels of assessment: clinical, ACG, and biomarkers.
Da, bună ziua. Ați confirmat cu ei cumva că vă aud?
Da, da.
Că eu nu vă aud, da?
Da, da.
Înseamnă că am eu o problemă la cabinet aici.
Da, da, mă aud.
Bine, succes.
Bine. So, other important thing is to distinguish among acute coronary syndromes, which is unstable angina, which is non-ST elevation myocardial infarction, and which is ST elevation myocardial infarction. And typical presentation of patients with unstable angina is related to presence of chest pain, ST changes, and this type of ST changes are not ST elevation, are negative T wave or ST depression, and negative cardiac biomarkers. When ACG changes are ST depression or T wave inversion, and cardiac biomarkers are positive, we are talking about non-ST elevation myocardial infarction, because positive troponin always means losing of cardiac myocytes. So unstable angina may progress to non-ST elevation or ST elevation myocardial infarction, but just as first presentation, distinguishable characteristic of unstable angina, it's negative troponin, negative CKMB without any dynamic of CKMB, and ST changes in terms of ST depression or negative T wave. We should point out that in 10 to 20% of cases, ACG can be normal, and only clinical experience and probably association to other risk factor may lead to diagnosis of unstable angina. Again, this is differential diagnosis, so unstable angina means negative troponin, ST changes but without ST elevation, presence of chest pain. You see here, this is the first level of decision, because in the presence we are just usually doctors working in emergency departments, and first of all we should assess probability of coronary artery disease. So chest pain is quite non-specific, and a lot of causes, cardiac and non-cardiac, clinical presentation, physical examination, characteristic of chest pain, associated pathology, we can make the diagnosis of unstable angina. Considering pathophysiology in acute coronary syndromes, but specifically in unstable angina, these are the 5 pathophysiological mechanisms, and these mechanisms were postulated by Braunwald in 1999. He wrote an editorial in Circulation, putting this figure, and nothing changed. Nothing changed. This is also contemporary view of pathophysiology of acute coronary syndromes clinically manifesting as unstable angina. So first cause, and this is most frequent, it's non-occlusive thrombus on pre-existing plaque. The second, it's progressive mechanical obstruction. The third, as prevalence, it's dynamic obstruction. The fourth, it's a secondary unstable angina when the coronary vessel, it's normal, and actually the causes ischemia. It's a disbalance between myocardial requirements and myocardial blood flow. We call it demand ischemia. And the last mechanism in terms also of prevalence, it's inflammation or infection. And many inflammatory diseases, and recently in COVID era, we saw a lot of acute myocardial infarction without plaques, without any thrombus in coronary arteries, just because of inflammation seen in small coronary vessels. And we had also in my department 6 or 7 cases of acute myocardial infarction post-COVID infection. This is also a table summarizing mechanisms of unstable angina. Please pay attention, because one of the questions probably you'll receive at the exam may ask, which is please enumerate, or please consider, or please provide 5 mechanisms of pathophysiology of unstable angina. And these are the 5 mechanism table for pathophysiology of unstable angina. Again, non-occlusive thrombosis, dynamic obstruction, progressive mechanical obstruction, inflammation, and secondary, as I told you, demand ischemia. First cause, it's atherosclerosis, because atherosclerosis is associated to plaque, which are limiting blood flow, and which is very bad and dangerous in terms of pathophysiological consequences. It's complication of plaque disruptions. The plaque has a lipid core inside of coronary lumen, and with very thin cap, and this cap may be ruptured. And when endothelium is ruptured, entire endothelium lose electrochemical properties, and a lot of thrombocytes are adhering to endothelium, and is leading to the occurrence of white clot. And then by progressing, by increasing obstruction, also blood flow, it's allowing that coagulation factor to be involved. First step, it's thrombotic clot, and the second step, it's fibrin clot produced by coagulation factor. This, it's also important in terms of treatment, because in acute coronary syndromes, the first step to prevent its white clot, so antiaggregants. The second step to prevent its excessive coagulation, so need for anticoagulants. I summarized here the steps of pathophysiology in terms of atherosclerotic complication for unstable angina, platelet adhesion, platelet activation, or platelet aggregation, and all coupled with activation of coagulation factors. You'll see also my presentation. I will send my presentation. And this is a typical example in terms of anatomical consequence. In the left side, we have a multi-slice cardiac CT showing here aorta, right coronary sinus, and the right coronary arteries with a lot of sequential plaques. And this image on the left side, it's a coronary angiography showing for the same patient dimension, the real dimension of atherosclerotic involvement from here to here. In terms of frame rate of coronary angiography, it's obviously better than frame rate of multi-slice CT, but the advantage of multi-slice CT, it's done by possibility to have also axial scrolling and transversal section. But this is a typical case of imaging for a patient with unstable angina. Again, summary, symptoms, ACG, cardiac biomarkers, and pathophysiology of unstable angina. In terms of diagnosis and symptoms, symptoms of unstable angina are similar to myocardial infarction and could be chest pain. And the location of pain is sometimes difficult to interpret. It could be in back, in neck, in joint, abdomen, and very, very common. Patients are presenting in emergency department with pain in the shoulders. Very common also, some associated symptoms are sweating, dyspnea, nausea, vomiting, and for patients with long-term history of coronary artery disease, sometimes they may present fatigue. However, there are some typical characteristics of chest pain in unstable angina. First, symptoms may occur at rest. This is totally different to stable angina. Stable angina is related to effort, and it's a stable condition. When angina is occurring during the rest, this is unstable angina. The second characteristic, it's becoming more common, severe, prolonged than the usual pattern of angina. So changing in pattern of angina, let's say the patient, your patient has a typical schedule of chest pain, 1 or 2 chest pain per week. When this pattern is changing, let's say the patient is describing everyday chest pain, this is also unstable angina. It's modificatory of temporary pattern of chest pain. Other type of changing in pattern of chest pain, the pain is becoming more severe. Let's say patient usually 6 months ago described chest pain of a span of 5 to 10 minutes relieved by sublingual nitroglycerin. Now he's presenting in emergency department describing chest pain 15, 20 minutes, not relieved by sublingual nitroglycerin. This is also unstable angina. And the next characteristic of pain in unstable angina, we discussed about change of the pattern, and this is a quite typical character, not responding to sublingual nitroglycerin. This is very, very important. Take care. This is one of the questions, very probably to be included in your multiple choice questionnaires. Characteristic of chest pain in unstable angina. In terms of diagnosis, because now we are in emergency department, in front of us it's a patient describing chest pain. We should be, first of all, medical doctors to discuss with our patient, to analyze characteristic of chest pain, if the pattern is changing, if it's not, or it's relieved by sublingual nitroglycerin, and then we should perform ACG. ACG is the first step in assessment of patients with acute coronary syndromes. And usually for patients with unstable angina, ACG may show ST depression, negative T wave, or even in 10 to 20% of patients, normal ACG. The third step, it's drawing cardiac biomarkers, troponin, high sensitivity troponin I, and CK-MB. When chest pain, it's quite typical of ischemia. When you have some STT changes on ACG, but cardiac biomarkers are in normal limits, the diagnosis, it's quite clear, of unstable angina. In terms of classification, in clinical practice, we are using Canadian classification. There is also, and you'll see in my text, Brown-Ball classification of unstable angina. A Brown-Ball classification, it's a combined classification including severity and pathophysiology of unstable angina. It's comprehensive, but it's quite difficult to use it in clinical practice. And that's why in clinical practice, we are using Canadian classification of unstable angina. And this type of Canadian classification of unstable angina is very similar with New York Heart Association class, is very similar with classification in PAD, in peripheral artery disease for claudication, is very similar to classification, ERA classification of atrial fibrillation. So again, take care. It's a question very, very frequently included in the multiple choice questionnaire classification of unstable angina by Canadian group. Grade 1, it's less severe, and grade 4, it's the most severe. And the grade 4 means inability to perform any physical activity without chest pain, or even chest pain occurring during the rest. So Canadian classification of unstable angina. This is our plan. And this is always our plan, not only in unstable angina, but also in any type of acute coronary syndromes and any type of pathophysiological condition, because we are discussing not about pathophysiology now, not about academic issues or scientific issue. We are just discussing about the patient. The patient is in front of us. And it's in front of us in emergency department, and we should carefully evaluate initial presentation. We should confirm if the patient has unstable angina or other type of acute coronary syndromes or non-cardiac causes of chest pain. When we decided that the firm diagnosis is unstable angina, we should provide risk stratification. And then, once risk stratification is provided, we should give immediately disposition decision, so where to admit the patients in ICCU care, in ICU care, on a regular unit, in observation unit. We are passing very fast and don't pay enough attention to disposition decision, but actually in clinical practice and has a lot of medical legal connotation, disposition decisions are quite important. We should offer medical therapies according to the severity of the syndrome and the pathophysiology behind of ischemia. We should decide invasive versus conservative strategy. Once decided the type of strategy, patient must be continuously monitored during hospitalization, and at discharge, the patient is not discharged into a chaotic environment. We should offer a discharge planning. In terms of confirmation, we should take into consideration differential diagnosis. And in practical terms, and most commonly in clinical practice, we should have a differential diagnosis of chest pain and the differential diagnosis of STT changes. Of course, first differential diagnosis is comparing with ST elevation, non-ST elevation myocardial infarction, but I should remember you that in both these instances, cardiac biomarkers are abnormal. With other type of acute coronary syndromes, we should distinguish, and this is clearly very important. And most of our mistakes in secondary hospitals and in community hospitals is differential diagnosis between acute coronary syndromes and acute aortic syndromes, let's say acute aortic dissection. Acute aortic dissection means an intimal flap in ascending aorta, and sometimes this type of flap may protrude in coronary ostia or may obstruct dynamically coronary ostia, and on ACG we will see ST depression or even ST elevation, and we are giving thrombolysis, which is a disaster, because in a disease associated to propensity to aortic rupture, we are giving thrombolysis. It's a disaster. So every time, when you consider diagnosis of acute coronary syndromes, we should remind that in 1 to 2% of the cases, the cause of ST depression or ST elevation, it's acute aortic dissection. And the treatment of acute aortic dissection in terms of medicines, pills, or surgery is totally different to treatment of acute coronary syndromes. Of course, we should distinguish by pain characteristic, by associated sign of symptoms diagnosis between pulmonary embolism and in some European countries in emergency departments there is a triple rule-out protocol with cardiac CT in emergency department. Cardiac CT, it's a highly performant CT, more than 64 slides CT, with capability to see coronary arteries, to see aortic walls and to see pulmonary vessels. And in this way, we may distinguish if the patient has pulmonary embolism by detection of thrombus in pulmonary artery. We may distinguish aortic dissections and seeing intimal flap in the aorta, and we may see coronary arteries and multi-size CT. It's perfect to diagnose coronary artery disease involvement. Other cardiac causes are pericarditis, but pericarditis is typically associated to inflammation. You'll see from history, you see when you discuss with the patient that the pain, it's becoming more and more important during respiration. Sometimes when you are very well experienced, it may detect pericardial rub. And also, when you are a very good doctor, you'll see on ACG the typical changes of pericarditis, because the dynamic changes of pericarditis are totally different by dynamic changes seen in acute coronary syndromes. Okay, we should consider pneumonia, and you should consider other non-cardiac causes like gastroesophageal reflux, which is quite common. And chest pain could be produced also by musculoskeletal abnormalities, and also panic attack and a lot of psychological behavior or psychiatric disorders may mimic chest pain. When diagnosis is not clear, when the patient presents with atypical presentation, you need additional exams. Additional exam to complete initial assessment, and initial assessment, it's clinical, it's ACG, it's cardiac biomarkers, but sometimes you need just radiography, sometimes you need echocardiography, and I should remember that echocardiography, it's mandatory when patients present with chest pain has associated dyspnea and any other sign of heart failure. Sometimes you need coronary computed tomography, multi-slice coronary angiography. Sometimes you need other type of high sensibility imaging studies like MRI or myocardial perfusion test. By this type of studies are just to further re-stratificate and patients with acute coronary syndromes, and to offer alternative therapeutic options when diagnosis is firmly confirmed. Practically, because again, we are medical doctors, our approach consideration should be, first of all, this patient with chest pain, is this chest pain associated to coronary artery disease? Actually, we should ask every time what is behind the patient presentation. The second and most important, how dangerous is this? Because we are talking about differential diagnosis. There are thousands and thousands of causes for differential diagnosis in different segments of pathophysiology. And we, as medical doctor, we must exclude the causes which are life-threatening for patients' condition. We are not able to exclude thousands of causes, but it's our job to exclude life-threatening pathologies. Sorry. Again, we are coming back to stage-by-stage plan. And in terms of confirmation and also risk stratification, we are using TIMI risk score. TIMI risk score, it's a quite useful risk score in emergency department or in the first hour during hospital admission to assess probability of coronary artery disease and acute coronary syndromes, and also offers some important clues for risk stratification. The components of TIMI risk scores, and also look in my text, it's also a subject included in multiple choice questionnaire. It's age, number of risk factor, history of coronary artery disease, aspirin in the last 7 days, more than 2 anginal episodes in the last 24 hours, recent STT changes, and elevated cardiac biomarkers. In terms of management for unstable angina, for sure management is directed to reduce myocardial oxygen demands because it's ischemia, improving myocardial oxygen supply. And when we are discussing for the first step of management, reducing myocardial oxygen demands, we are discussing about the beta blockers, and beta blockers are decreasing heart rate and blood pressure and finally myocardial oxygen consumption. When we are discussing about improving myocardial oxygen supply, we are talking about coronary vasodilators, and fortunately are very few, nitroglycerin. And we are talking about mechanical interventions, percutaneous coronary interventions, so balloon angioplasty plus or minus coronary stents. And we are talking also about CABG, coronary artery bypass grafts. Also, an important component of management is to assess patients' risk and to estimate progression to severe complication. This is also an important step with a lot of medical legal connotation. So again, reducing myocardial oxygen demands, improving myocardial oxygen supply, and assessing patient potential to evaluate to complication. It's about unstable angina. And based on the risk stratification, we should decide if our patient deserves a conservative strategy. What does it mean, conservative strategy? To give medication, anticoagulants, antithrombotics, beta blockers, ACE inhibitors, statins, and to wait and see what's happened. This is conservative strategy. The second strategy, it's an aggressive one, and it's related to early revascularization in terms of balloon angioplasty and cardiac surgery with surgical revascularization. These two strategies are totally different, and we should decide very fast, but in the same time very wise, which is the best strategy for our patients. And read the text, which I will be sending you very soon. we should decide the strategy, conservative versus invasive strategy. In 60–70% of cases, we are using percutaneous angioplasty, balloon angioplasty, and stents, and only in 10–15% of cases we are using coronary artery bypass grafts. And most often consideration for choosing surgical revascularization are related to coronary anatomy. So let's say left main stenosis, poor left ventricular function, and poor left ventricular function still remaining a good indication for CABG in patients with unstable angina. 3 vessel disease with mandatory involving proximal segments of LAD, left anterior descendant artery, association with diabetes. In contemporary trials, association with diabetes, it's still a factor associated with poor results after angioplasty. That's why the best idea in patients with diabetes is surgical revascularization. And of course, and this is quite intuitive, when patient has associated severe valvular disease, it's better to offer cardiac surgery. Pay attention, pay attention. This question could be a question included in a multiple choice questionnaire. Again, we are coming back to our plan, and we are talking now about disposition decision. And these are indication when patient presenting in emergency department, it's directly admitted in ICU care. And there are several criteria. Read the text to find out explanation for each of the other criteria. But in the few words, these are severity criteria, making clinical presentation quite unpredictable. And this is the reason why this type of patients with this criteria required admission in the ICCU. This is a scheme, and this is a nice scheme and very useful in emergency department when we already decided to use one of the 2 strategies, invasive or conservative strategy. And again, please read the text. These are considerations, several considerations, when we are deciding early conservative strategies in unstable angina. In non-ST myocardial infarction, recent guidelines, European Society of Cardiology guidelines, still recommend utilization of GRACE risk score. GRACE was the largest registry, including patients with acute coronary syndromes, and the GRACE investigators established by post hoc analysis a risk score based of clinical variable included in this study. And for non-ST elevation myocardial infarction, GRACE risk score is very useful to dictate type of strategy, early invasive or conservative. For unstable angina, decision to perform early invasive versus conservative strategy is not very clearly stipulated, but the authors of the guidelines consider that the elements included in GRACE risk score should be also considered as decisional in patients with unstable angina. And on this slide are recurrent angina, elevated cardiac biomarkers, new ST depression, heart failure, hemodynamic instability, sustained ventricular tachycardia, history of recent PCI or recent cabbage, or left ventricular ejection fraction less than 40%. Which are the target of the treatment? First of all, plaque rupture. We are discussing that this type of pathophysiology is most commonly involved in evolution and in pathology of unstable angina, and these patients needs high doses of statins. When it's white clot, it's a platelet clot with thrombocytes cascade. We are talking about platelet adhesion, activation, and aggregation, and patients are requiring medication to block all these three steps. And this type of medication, it's represented by anti-aggregant medication, aspirin, 2B3A inhibitors like clopidogrel, ticagrelor, or pasugrel. And we are talking about very, very interesting medication, 2B3A inhibitors, glycoprotein inhibitors, integridine or apiximab. And I will show you on Monday the mechanism of action of each of these medication. We should consider clotting cascade, because clotting cascade is an important event in progression of acute coronary syndromes, and it's associated to severity. So we are needing anticoagulants, to consider anticoagulants for our patients. And we are also considering that myocardial oxygen supply can be compromised in patients with unstable angina, and this is an excellent and rational explanation why to use beta blockers, nitrates, and calcium antagonists in our patients. Please take a look here, because these are a very good example of type classes, pharmacological classes type of medication used to treat patients with unstable angina. You'll see a lot of details in the text. And we should have a part of anti-ischemic therapy, looking also not only at antiaggregants, anticoagulants, or revascularization, but we should minimize any other potential condition who will increase myocardial oxygen consumption. In other words, we should offer our patients a rest with a non-stressant environment. We should start very soon nitroglycerin when chest pain is prolonged. We should offer oxygen therapy, especially for patients with low oxygen saturation. Sometimes chest pain is unbearable and we need morphine. Very rare in contemporary days we are giving morphines, but keep in mind this is one of the last resorts for treating patients with severe chest pain. Beta blockers, we are saying in a cardiological environment that beta blockers are the best ever therapy for treating chest pain when ischemic cause is reality behind of clinical presentation. And also don't forget ACE inhibitors. We have some clinical trials, very successful clinical trials showing that early initiation of ACE inhibitor therapy, ramipril, captopril, and enalapril in patients with acute myocardial infarction or any type of acute coronary syndromes, it's life-saving. One of the last components of management is monitoring and discharge planning. As I told you, we should offer the patient at discharge very clear instruction plans, what to do, when to come again to reevaluate, what is a schedule for your therapies, what's happened with uncontrolled risk factors, what should I do, when to smoke, when to stop smoking, when to resume physical activity, when to come back to my job. All these questions should be answered before discharge. Otherwise, it becomes a nightmare. The patient is lost and the doctor is happy, but your job as physician, it's as patient should be happy and the doctor should be workable. And finally, don't forget of A, B, C, D, E, aspirin, ACE inhibitor, beta blockers, statins as cholesterol-lowering agent. Don't smoke. Focus on the right diet. And don't forget to resume physical activity, exercise when it's possible, whenever your medical doctor is recommended. This is my teaching lecture. Please ask your questions if you have. Wake up.
I think it was clear.
Thank you.
Was clear?
Yes.
Yes.
So, my objective is to give you a clear perspective on differential diagnosis between unstable angina and ST or non-ST elevation myocardial infarction. And this differential diagnosis is based on ACG and cardiac biomarkers. ACG is with ST elevation when we are discussing about ST elevation, myocardial infarction, and cardiac biomarkers are always abnormal in patients with ST or non-ST elevation. Very often, unstable angina, it's a progressive condition and may lead to non-ST or ST myocardial infarction. We should consider a management plan. We should consider classification. We should consider which are the best decision for our patient, invasive strategy, early invasive, or a conservative strategy. We should have in mind some criteria for risk stratification. We should provide the best treatment and at least theoretically the components of management is to decrease myocardial oxygen consumption, to provide an adequate and appropriate blood flow, and to treat in surrounding environment, let's say associated heart failure, valvular disease, and the constellation of risk factors which should be evaluated and kept under control. Don't forget of disposition decision when a patient with unstable angina should be admitted in ICCU. Don't forget when your patient with unstable angina is requiring surgical revascularization. Don't forget to continuously monitor the patients during hospitalization because unstable angina. 10 years ago, 15 years ago, we were calling unstable angina as intermediary syndromes because very often was an intermediary step through progression to ST elevation myocardial infarction. And finally, don't forget to give a discharge instruction to your patients. That's all with the course.
Thank you.
Thank you.
so much.
Thank you, Professor.
Please don't close. You are on hold?
Yeah.
Okay. Bad news. Bad news for you. Kuzmina Kozmin na Parush.
Yes.
Okay. So you are alive.
Of course.
Okay. Can you present 1 minute on Monday, 1 minute, mechanical complication of acute myocardial infarction? 3 slides. Mechanical complication of acute myocardial infarction.
Yes.
Okay. Who is Nicholas Papanasakis?
Yes, sir.
So, can you present 1 minute, 3 slides, contraindication of thrombolysis? Yes or not?
Yeah, sorry, I was writing it down. That's fine.
Okay, this is perfect. Who is Ale El Yusufi?
It's me.
Okay, can you present 1 minute, 3 slides, protective mechanism during acute ischemia?
Yes, okay.
You should discuss about collaterals. You should discuss about hibernating myocardium, stunning, and finally about preconditionation. It's a very nice topic.
Excuse me, can you please repeat the 3 things that I should present?
You should discuss about developing of new collaterals, hibernation concept. In acute condition, you should discuss about stunning, and finally about preconditioning.
Okay, thank you very much.
1 minute, 3 slides.
All right, thank
And
you.
who is Prashalini Bala Singh?
Yes, Professor.
Okay, can you present 1 minute, 3 slides, ischemic cascade? Ischemic cascade.
Okay, Professor.
Okay, and the last but not the least, who is Dina Nader?
Yes, doctor.
Okay, can you present 1 minute, 3 slides, time due to balloon, concept in acute coronary syndromes?
Doctor, could you please repeat the beginning?
Yes. I would like very much to present 3 slides about one concept, time due to balloon.
Okay.
When you are looking on Google or Wikipedia, you'll see time due to balloon. It's a measure of effectiveness of cardiac laboratories and hospitals treating patients with acute coronary syndromes. Yeah, agree?
Yes, doctor.
Okay. And Who is Halime Betul Akyol?
Hello, yes, doctor.
Okay. Can you present 1 minute? 1 minute. 3 slides. 3 slides about Grace risk score.
Yes.
Okay. Who is the last? Saha Tatur?
Yes.
Yeah. Can you present on Monday? 1 minute. 1 minute. 3 slides. 3 slides about echocardiography in acute coronary syndromes.
Okay.
Okay. So I suppose that you send me an email address. Miruna Eng stud umefesidiro. This is?
Yeah, it's our serial leader's email
Okay.
address.
I will send you some materials, a text, some PowerPoint presentations on this email address, and that's all. We'll meet on Monday at 12:30.
Thank you, doctor.
Bye-bye.
Thank you.
So much. Bye.
Thank you. Goodbye.
Thank you.
Thank you.